Stephen Rowley, Clinical Director, nurse by background of the Association for Safe Aseptic Practice that oversees ANTT. This presentation is going to be fast. Okay, so it's quite a few slides to get through. I'm going to try and keep to time. I thought these were two great questions to frame a conference. My wife, when she looked over the shoulder, thought they were two good questions to evaluate me and my role at home. The answers were, what is your role? And no, you don't do very much, and certainly not enough. To get back to the kind of theme of the day, AMR, there's a lot, in my experience, much of the work around AMR I see in practice is largely around microbial stewardship for very good reason. I'm not going to be talking about that at all. That's not my gig or anything I know too much about. I'm here to build on the message throughout the day and in the title of the conference, which is this, that the antibiotics are running out. The projections are quite scary of what the future might look like in that situation. And the obvious thing to me, running an organisation like we do, is that the key message has got to be prevention. Not something that we fall back on if we don't resolve the antibiotic issue, but right at the forefront right now. So just to check we're on the same page, we would say that aseptic technique, whatever that means to you, is a critical clinical competency. Is everybody happy with that statement? Yeah? Anybody want to come out and argue? No. It's a pretty critical clinical competency. Kind of defines the interaction between us as dirty microbiologically, dynamic healthcare professionals delivering pretty risky procedures to patients when they're most at risk. And are people happy with the statement that when this isn't delivered properly, this critical clinical competency, that patients are likely to get harmed or worse? Everyone think is that over-egging it? No. And is everyone happy that essentially, give or take, aseptic technique breaks down into about 5 or 6, maybe 10 or so core actions that one has to do in an integrated way to be successful? Yeah? Okay, so that begs the question. How confident would you be tonight going to a local hospital, not necessarily where you work, with a loved one, who had to be admitted in ED, have a number of aseptic procedures, maybe some blood drawn, a cannula, then get admitted, and over a week have a number of aseptic procedures from IV therapy to wound care, maybe a bit of surgery, and that every occasion, every one of those components would be delivered in front of you to your loved one? Who would put their hand up and say, yeah, I'm pretty confident about that? Who would say, I'm reasonably confident about that? Not a single hand in the room. So there lies the challenge. We got one. Oh, it's a head shake. It wasn't. It was a mistake. So here's a man looking at his arm. I don't know if you saw this. This was published very widely last year when Andy Murray had an operation in a private hospital in London, and everyone made hay at the rather big mess of his IV therapy on his arm. So this is a man who definitely probably didn't receive all the components of aseptic technique. Now, he looks pretty happy about it. Why this, I don't know. Maybe it's because he's Scottish. Or maybe as a layperson, effectively, Andy doesn't understand the risks of having these procedures. And, of course, he doesn't particularly need to. That's our job. And legally, morally, and ethically, again, that's what we should be delivering every time. So is aseptic technique delivered routinely? Well, we haven't got the time today to unpick that, but essentially, take a good look in the literature, and the answer is universally no. And that is reflected by your own vote this morning. So why is aseptic technique so historically challenging? Why, after kind of 100 years certainly 60 years looking at infection control, has this not been nailed down as a clinical competency? Lots of reasons. We don't have time to go through these systematically this morning. I'll just give 2 insights into that question. Hand cleaning involves one easy action. Think of the millions, if not billions worldwide, have been invested in getting this key action done in terms of compliance every time. And we know that the best efforts on a day-to-day basis, looking at the biggest kind of research around multi-censored studies, it's generally accepted that hand hygiene compliance before a procedure that requires hand hygiene compliance, I'm not talking about social hand hygiene compliance in hospitals, but procedure-related compliance is still around 50%, depending on where you read. Aseptic technique, in contrast, isn't as well defined as hand hygiene. Involves 5 or 10 components which have to be integrated in a certain way. So, of course, the challenge is obvious and shouldn't be underestimated. This is a very potted history, but in the last 50 years or so, what have we done around aseptic technique? We spent an awful lot of time looking at the definition and pontificating it and coming up with probably 30 or 40 different terms for aseptic technique and what that might mean. And it means very different things generally to different people. Now, that's not so helpful when, again, over the last 30-odd years, any stakeholder guidance, almost universally, the major stakeholder guidance, the World Health Organization, INS, AVA, IPS, RCN, internationally, have by and large described or prescribed aseptic technique and not described it, which is all very well if we were all born with a fundamental knowledge of how to apply aseptic technique. But of course, last time I looked, that wasn't true. It's certainly not true of my kids, who certainly know nothing about aseptic technique. So a key message, prescription without description isn't safe. It's no more safe than saying, do pulmonary resuscitation, do CPR. That's it, that's your training, that's your update this year. No more than that, just do it. Or is the world a little bit safer that internationally we almost have this standardized protocol where the definition, the terms and the rules and the process are universally laid down, evidence-based and understood and trained. Who's had CPR training in the last year? Yeah, pretty much everybody. Who's used it? 5%. Who's had aseptic technique training in the last year? 5%. Who's used it? 100%. A complete mirror. Which one was more likely to have more beneficial effects on patient outcome? Training in this critical clinical competency or CPR training? So we do some strange things as healthcare organisations and societies, don't we? I'm not advocating we shouldn't be investing in CPR. We're obviously advocating there's some way to go in aseptic technique training. So that was kind of a potted history. So this is where ANTT came in. It was designed to address the anomalies and ambiguities in practice. A comprehensive framework was originated some time ago now, over a decade now. Slowly that's manifested itself in practice. Heather Loveday from EPIC 3 once said at a conference last year that there's evidence that says it takes 17 years to embed a new concept. I would say she was about 2 years out. So ANTT addresses historical ambiguities of aseptic technique, provides a universal framework and practice language, and to enable safe, consistent decisions about aseptic technique. And that's ANTT in a nutshell. That's the framework. It's a comprehensive framework, meticulously defined. So where is the NHS with ANTT? So ANTT has become an international phenomenon, which I'll explain a little bit in a minute. But today, let's focus on the NHS. Where are we with aseptic technique? So the association set out to address this question last year. We did a Freedom of Information survey through the FOI process, where in theory, all hospitals have to reply. Of the 228 English trusts that we used, that's everything from mental health to acute to community, we had a 92% response rate, which was pretty good. What we asked was essentially where the organisations were in meeting the requirements set out in the Health and Social Care Act. I think it came out around 2008. It's been updated a few times. It's still current today. That every organisation, for example, when inspected by the CQC, if they happen to look at this, which they sometimes do, would expect every organisation to have a single standard aseptic technique that was demonstrable by staff training and competency assessment and ongoing audit of compliance. So we asked trusts where they were with that. Before we whiz through the results, let's just take a step back. In the 1990s, this was the last survey I did. It was a lot quicker and dirtier than the one we did last year, but it gives a flavour. And this is what we found around aseptic technique. There were just so many terms. It was impossible to make anything of it, and hence ANTT was born through this ambiguity. The findings. 81% of English trusts, through a transparent, recordable process which will be published and in the public domain shortly this year, stated ANTT was their single standard aseptic technique. 12% of trusts said they have an alternative standard. That's 12 alternative individual standards. And 6% of trusts said, hey, we missed that party. No, we don't have anything at all. So I'm not looking at my watch because I'm getting impatient or anything. It's got a stopwatch on. There we go. And let's compare that with, actually before we do that, let's just have a closer look at the exceptions to the organisations using ANTT. When we looked at the data in more detail, it didn't really stand up to much scrutiny, the 25% that didn't use ANTT. A mix of organisations that either said they didn't have a standard or they did, said they were actually using ANTT in part with other things. So it's all a little bit confusing what this looks like, and this certainly does require a little bit of a deeper dive. So not a lot of a confidence factor in what that 25% represents in terms of a standard aseptic technique. Now, let's have a quick look across 3 other countries in the UK. That was England. Let's look at Wales. That's a very easy one. The government mandated ANTT in Wales about 5 years ago. We're evaluating that with Public Health Wales and NHS Wales right now. In theory, that's 100%. It was mandated by government, and a lot of resource and time and effort a programme put behind that. The interesting one was Scotland. Scotland aren't really meant to use ANTT because they delivered their own offering via the Department of Health website and system a few years ago now, called Aseptic Technique. You may have heard of it, and the results were interesting. 50% of organisations stated they were using ANTT as their single standard. So there's some interesting questions there. And we're hoping, through Linda's support, hopefully, and other parties, that maybe we can join the dots up here across the UK. So there's one offering that everyone has access to. We also looked at the question of, does the single standard, the type of single standard aseptic technique, have any relation on the kind of core component parts of effective clinical governance? We asked organisations, did they have their single standard in policy? Did they provide education and training, competency assessment, and ongoing audit to look at compliance? And importantly, periodic competency assessment, not just one big bang implementation, tick a box, but ongoing, repeating the competency assessment, rather like CPR annually. As you can see, not so strong in ongoing periodic assessments, pretty strong in policy. Now, there's obviously not always a strong correlation between policy and practice, so a number of questions raised. In a nutshell, and sorry to rush this, but ANTT is firmly established as the single standard aseptic technique in England and Wales and is used in 50% of Scottish hospitals, and interestingly, growing quite rapidly. The private sector actually has a higher utilisation with ANTT of nearly all organisations, the big organisations, BMI, Nuffield, and so on, having a national approach. Only Wales mandated ANTT, and that's a real credit. That's a real strength of the project. This was a project that came ground up through clinicians like yourself, embracing ANTT and doing the hard work locally. And this is the sum of those parts. So a big thank you and respect to the many clinicians and who have supported this project over the last decade. I would say there is no credible alternative to ANTT. Surprisingly, there is still no comprehensive framework out there other than ANTT, which is probably a good thing now because we're seeking to establish a single standard. And it would seem that ANTT better facilitates clinical governance, not surprisingly. It provides a solid framework and some of the prerequisites required for that. So, again, not surprisingly, many organisations and stakeholders along the way have referenced, endorsed ANTT, too many to mention. But the interesting thing is, this is an NHS focus today, but what we've been striving to as an organisation, rather ambitiously at first, but now it's becoming a clear reality, is a single standard internationally. Just like CPR. We've got somewhere between 25 and 30 countries using ANTT in a significant fashion. Obviously variably. Some still quite organic, relatively new, but some increasingly being mandated by government, like Australia, which was effectively, like Wales, like Nigeria is going to be, like Poland looks like it's going that way. A quick whiz through some of the achievements just in last year. The American Vascular Access Society, or should I say the Association for Vascular Access Society, with real global reach in this particular specialty, has endorsed ANTT explicitly. INS guidelines, the infusion standards guidelines, which again have real global reach. Latest 3-year peer-reviewed journal coming out next year, we're very much part of. ANTT throughout. This will have a tremendous impact across the states and, again, with global reach. The World Health Organization here for urinary catheterization beginning to show signs of using ANTT to articulate best practice and aseptic technique. The Australian guidelines for prevention and control of infection. The Australian government, by accident, I would say, inadvertently mandated ANTT over 10 years ago, recently updated, 2019, and effectively done the same thing again. That's why ANTT is pretty much a de facto standard in Australia. We have a whole reach of projects. This is a real strong clinical network, the ASAP, internationally. We have multi-centre studies in Poland. We have neonatal projects and have had for 3 or 4 years with a national programme in Russia. Yes, ANTT is largely used in acute settings, but we're seeing ANTT very commonly now in military services, paramedic services, and humanitarian services. We have a project with MSF, Médecins Sans Frontières, where my colleague has been to some pretty challenging places to deliver aseptic technique, like the South Sudan and so on. So one single international standard for aseptic technique is actually looking like a possibility. And I would say that the advantages are as profound as they are perhaps as obvious. A quick check if anyone's wondering, why did we trademark it? And well, very simply, historically, people take terms of aseptic technique, tweak them to death, and they become genericized and mean nothing. So clearly, ANTT is there to be used. The trademark was put on there for advice, and it seems to have sent messages that this is something that isn't there to be tweaked. The whole power of ANTT is it's a robust framework that needs to stay in one piece. One would imagine that the success of a dissemination of ANTT would be a sign that we've kind of got that balance pretty much about right. So is it party time to close up? Do we walk away now? And I think the answer to that, in context of the day, are we doing enough? Have we done enough? And what is my role? Is no, let's be realistic. We all know in infection control especially that the gap exists between theory and practice, between policy and practice. Compliance is the holy grail, and there's clearly signs that there's some way to go in getting the compliance right around ANTT and aseptic technique in the NHS and internationally. We'd be very foolish to walk away now thinking so many trusts are using it in the UK, we can walk away. We would say as an organisation that any organisation that wants to get aseptic technique right has to achieve the 4 Cs. It has to be concerned, for example. It has to have the right surveillance. It has to have clarity. It has that with the ANTT framework now. And if you have the clarity through a robust framework, you can now be in a position to achieve competency assessment and strive to compliance. So those organisations in the FOI are on the way in terms of the infrastructure, but that holy grail of compliance should not be underestimated. So last 2 slides, what should the NHS patients expect from every one of us in the NHS? We would say that is infection surveillance that's relevant to ANTT. Routine NHS audit of ANTT safety standards. And an NHS standard approach, it's there, it's very, very close. Still a little bit of work to do. And ANTT education and competency assessment for all NHS staff. And I'm sure there are ways that we can make that easier as an organisation. So, our message is ANTT is significantly contributed to the world of infection prevention. We've laid a foundation for going forward in this area, but let's not kid ourselves. This is probably base camp. And we certainly don't want to be going back now. And the way is up there to the top. But that's the challenge now, is another step change to get from where we've got in laying down the foundation to striving towards the holy grail of achieving compliance so that every patient gets ANTT, all those components on every occasion, not just occasionally. I'm going to be doing a workshop with Philip Howard. Professor Philip Howard is going to talk about AMR a little bit in the afternoon workshop, and then I'm going to follow on and do a session on ANTT. So that's where the nitty-gritty of what ANTT is. If people are interested in understanding a bit more about competency assessment, how you implement it, and so on, we'll take Q&As. That's where we'll be this afternoon. Thank you for listening, and have a great day. Thank you.